For today's session, we have picked up a relatively uncommon childhood tumor, which we all love to treat, that is malignant germ cell tumor. And why we love to treat it simply because it has an excellent prognosis and it is so-called easy to treat as well. However, still a substantial amount of controversies exist in the context of management of malignant germ cell tumor in pediatric age group, especially in the context of the stratification and the platinum agent of choice and the different other aspects as well. To learn and educate ourselves on this tumor, we have a discussion in which we have three discussions today. First will be a case presentation of an interesting case of malignant germ cell tumor to be presented by Dr. Ichita Tiwari. She is a fellow of pediatric hematology oncology at the Rajiv Gandhi Cancer Institute and Research Center, West Atlanta. Over to you, Dr. Ishita. You can start presenting.
Thank you, Dr. Roy. So, good evening, everyone. I'll be presenting a short case today. So this was a 1 year, 2 months old male resident of Haryana who presented to our side with complaint of swelling in left scrotum for the past 2 months. The informant was mother and seemed to be reliable. So according to mother, the child was apparently all right till 2 months back when she noticed that he had a swelling in the left scrotum. The swelling had an insidious onset and it gradually progressed so much that the left scrotal size was almost 4 times the size of the right scrotum in the past 2 months. It was not associated with any pain. There was no redness around the swelling, and there was no diurnal or postural variation appreciated in the size of the swelling. There was no apparent history of trauma. There was no history of fever or crying during micturition to rule out any infective focus. There was no constitutional symptom in the form of weight loss, pallor, bleed from any side, or any similar swelling elsewhere, just as to rule out any long-standing illness or malignancy. The past history was not significant. The family history, the child was the only issue, and there was no history of cancer in family. Birth history was uneventful. Child was a full-term normal vaginal delivery, and there was no history of any prolonged hospitalization. Developmental milestones were age appropriate. He was immunized according to the national immunization schedule. He was vaccinated till 9 months of age. And the dietary history was adequate for the age. Like he was weaned off post 6 months of adequate breastfeeding, and he was on complementary feeds till there. So for the complaint of the left scrotal swelling, they went to a local practitioner and where an ultrasound abdomen was done, and it showed a large heterogeneous solid mass lesion in the left testis, measuring around 6 into 5 into 4.5 centimeters. So a possibility of malignancy was kept and the child was referred to our site for further workup. So when the child presented to our site on the clinical examination, in the general examination, child appeared like a well-looking, playful child. The anthropometric measures were normal, as within normal limits as per the age. There was no pallor, icterus, edema. There was no lymphadenopathy, and especially there was no left supraclavicular lymphadenopathy. The vitals were stable, and he had a pulse rate of around 120 per minute. Respiratory rate was 28 per minute, and blood pressure was 90 by 60 millimeter of mercury, which was within the normal limits for the age. In the local examination, while inspection, a left scrotal swelling could be seen, and the swelling was oval in shape. It was approximately 5 into 4 centimeter in size. The swelling appeared diffused, but it did not involve the groin. The skin over the swelling was stretched with the loss of the normal texture, and there was loss of rugosity. There were no inflammatory signs around the swelling, and no redness, erythema, ulceration, or sinuses could be appreciated. While crying, the cough impulse was negative, and the right scrotal sac appeared normal. On palpation, there was no tenderness or any local rise of temperature around the swelling. A swelling of size around 5 into 4 centimeter could be palpated in the left scrotum, which was firm in consistency, mobile, and had a smooth surface. It was non-fluctuant and non-pulsatile. The overlaying skin was stretched, and the swelling was limited to the testes, so it was possible to get above the swelling. So the confirmation of the negative cough impulse was done with palpation. and transillumination test was negative. While palpating the swelling, one could appreciate that the involved testis was not palpable separately from the swelling, so it appeared like a testicular swelling. And the other urogenital structures like spermatic cord, spermatic cord was palpable and it appeared normal in texture. The contralateral testis was palpable in the right scrotal sac and it was of the normal size of around 2 into 2 centimeters. There was no palpable regional lymphadenopathy, like inguinal lymph nodes could not be palpated, and even in the systemic examination, the supraclavicular lymph nodes could not be palpated. Rest of the systemic examination was normal. There was no palpable mass in the abdomen. The chest appeared clear, and the cardiovascular system was normal. So this was about the history and examination. And if I have to summarize the child, so this was a 1 year, 2-month-old male with a short history of 2 months of a painless, progressively increasing left scrotal swelling with no history of trauma or other constitutive features. On examination, this child had a firm, non-tender left scrotal swelling, left scrotal mass, which was most probably testicular, without any signs of inflammation, and with negative cough impulse as well as negative transillumination test, with the contralateral testis normally palpable in the other scrotal sac. So on the basis of this, I would like to put a few differentials. So my first differential would be, this appears like a testicular mass, which is progressively increasing, painless testicular mass. So I would like to keep testicular malignancy as the first differential. Then the other differential could be a paratesticular mass, which is like quite common as in RMS in this age group. But since the testes could not be separated, could not be palpated separately from the swelling, so it is a bit of an off point. Then third, I would still like to keep congenital hernia as one of the possibility, but the negative cough impulse kind of rules against it. Then we can also have an encysted hydrocele that can present this way, because though the transillumination test was negative, but sometimes in the encysted hydrocele there is thick fluid, so even it can have a presentation like this. Then there can be traumatic swellings, or there can be varicocele, and there can be infective swellings, but usually I would like to keep them a bit lower down. And also, seeing the age of the child, there can also be the leukemic deposits, that is the testicular swelling. It can be a leukemic involvement, but since there were no constitutional features, as well as there were no swellings palpable, no lymphadenopathy or any pallor, anything, other features suggestive of leukemia, so I would like to put it a bit down. So this is about the case. Then as the child presented to us, so we suspected a testicular tumor. And so after history and positive clinical examination, he underwent the baseline tests, which were complete blood counts, renal function test, liver function test. Then tumor markers were done, and serum alpha fetoprotein, beta HCG, and LDH, all three were done, and it showed an increased alpha fetoprotein. So this indirectly points towards the germ cell tumor, malignant germ cell tumor of the yolk sac histology. So as for the next step, we did the staging workup, and we did CECT abdomen along with thorax. So in the contrast enhanced CT of abdomen, we found a heterogeneously enhancing left scrotal mass around 6 into 5.6 into 4.5 centimeter. Along with that, we found a necrotic left para-aortic lymph node, which is actually the drainage of the left testis. So, and the size was quite significant, around 4 into 3.5 into 6.7 centimeter. So this was the abdomen. Then in CT thorax, we found multiple pulmonary nodules. So that seemed like a metastatic disease. So as for management, we went ahead with the family, we counseled the family, and we went ahead with surgery, in which we did a high inguinal left radical orchiectomy. The incision was inguinal, and the gross specimen, it showed us, so we took out the whole of left testis, epididymis, along with the spermatic cord till the level of internal inguinal ring. and it showed us the tumor, which was, it showed us that the whole testis was replaced with a grayish white lesion, but the surface was smooth, and the capsule, that is the tunica albuginea, it was not breached. So the tumor was located, it was locally in the testis. Spermatic cord was not involved. It was normal in texture, and the tumor did not seem to invade tunica albuginea, epididymis, or the cord. In histopath, the findings were confirmed. We found that the tumor was limited to the testis, and the histology came out to be yolk sac tumor, the one that we were, which is quite common in this age group, and lymphovascular invasion was present, but the resection margins were negative for the tumor. So if we try to consolidate all of this information, so now we have a tumor which is malignant germ cell tumor of left testis with the histology of yolk sac with raised serum alpha fetoprotein, and there are signs of metastasis because there is retroperitoneal lymphadenopathy along with the bilateral lung mets. So it makes it metastatic malignant germ cell tumor of left testis, prepubertal yolk sac. So according to the staging, it becomes COG stage 4. And according to the MAGIC risk stratification, it becomes the standard risk. So we manage the child post-counseling, we manage the child with adjuvant chemotherapy. So at our center, we are using the PEB. So we give 4 cycles of PEB, and post that, we followed the serum alpha fetoprotein trend. So the baseline was 8,750, and the post-surgery, that is like post 3 to 4 weeks post-surgery, it was 1,560. So we start 1,560 nanogram per ml. So we started off with this alpha fetoprotein level, and post 2 cycles, the serum alpha protein level, it normalized. So post the adjuvant chemotherapy, we did repeat imaging, and we found a significant response, like the retroperitoneal lymph node, the size regressed, as well as the metastatic deposits in the lung, they responded well. So that was the treatment. And after that, we have been following up the child. So the child has completed his treatment in August this year. So he has had 2 follow-up visits with us, and we are following him up on every visit with clinical examination, the chest x-ray, as well as the ultrasound of abdomen and the tumor markers. So all of it has been well till now. So this is about the case.
All right, Rishita, thank you for presenting the case. There are a couple of questions, but I think we can take those questions at the end of the session after all the talks are over. Now, I would request you to stop sharing your screen, and I would request Dr. Sandeep Jain to start presenting his talk. So sir will predominantly talk on the staging and the stratification and the consensus and the controversies around this aspect of germ cell tumor. Sir is a consultant of pediatric hematology oncology at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Over to you, sir.
Pritam, can you see my slides? And can you hear me?
Yes, to both, sir.
Okay, okay. Thank you, Shita, for presenting the case. So I shall be speaking about staging, risk stratification, and prognostic factor of germ cell tumor. So germ cell tumor in children arises from primordial germ cells, which are destined to be either ova or sperm. In the intrauterine life, these primordial germ cells migrate from yolk sacs to the gonads. However, they may follow aberrant path and get located in the extragonadal sites. If there are some genetic alteration in these primordial germ cells, they can give rise to germ cell tumor. So based on the location, they can be classified as either cranial or extracranial. And we shall be discussing about extracranial germ cell tumor today. And they can further be either gonadal or extragonadal. Now, depending on the tumor markers, they can be classified as secretory if tumor markers are high, and they are referred as non-seminomatous germ cell tumor. And if tumor markers are normal, they are classified as seminomatous germ cell tumor. And based on histology, they can be classified as yolk sac tumor, seminoma if it's in the testis, dysgerminoma if it's in the ovary, embryonal carcinoma, choriocarcinoma, and mixed germ cell tumor. So let's now move to staging and risk stratification of germ cell tumor. In gonadal germ cell tumor, most of the time we do upfront surgery as a part of treatment. However, this is not possible in extragonadal germ cell tumor because they are either very large or their location is such that it precludes the upfront surgery. So staging most of the time in this patient is surgico-pathological. So it is very important for us to see the pre-surgery radiology report and post-surgery histopathological report because it contains very important piece of information that are crucial for accurate staging and risk stratification. So I shall be showing in my subsequent slide what all we need to see in the radiology and histopathological report. Another important component of staging in germ cell tumor in children is tumor markers, which form an important component of staging. So I shall be discussing these things first. Let's start with the tumor marker. So there are basically two main classes of tumor marker. One is oncofetal substances, which is alpha fetoprotein secreted by the trophoblastic cells, and beta FCG, which is secreted by the syncytial trophoblastic cells. And the other class is cellular enzyme, which is like lactate dehydrogenase. So these tumor markers help us in diagnosis of the disease. They also indicate disease burden because more the tumor marker, more is the extent of disease at the diagnosis. They help in the staging and prognosis because it has been seen in many studies, the rate of fall of tumor marker is associated with outcome. Then after completion of the treatment, it also helps in surveillance because they are very sensitive marker to predict the relapse. Often rise in tumor marker precedes radiological and clinical relapse. So they can be used as a marker of surveillance. Now coming to first tumor marker, that is alpha fetoprotein, the half-life is 5 to 7 days. Why is it important to know this half-life? Because in the stage 1 tumor, when we keep this patient under observation, these tumor markers should normalize within 4 to 5 half-life. So it is very important to understand this. Then AFP is raised in yolk sac tumor, immature teratoma, and mixed germ cell tumor. Then there are certain other important things that we should know about the alpha fetoprotein. We should know age appropriate cutoff of AFP in infancy, especially in the premature babies where it can be very high. So whenever we have a child with a raised AFP during infancy, we should refer to this nomogram and try to ascertain whether this AFP is physiological or pathological. Generally, this normalizes by 8 months of life. Then AFP is not raised in pure choriocarcinoma or pure seminoma. If we do upfront surgery and the histology is seminomatous, but AFP is raised, we have to treat this child like a non-seminomatous germ cell tumor. Then there can be slight elevation of alpha fetoprotein in hepatocellular carcinoma or because of any injury to the lung, which may be because of underlying cirrhosis or hepatitis, or any drug used like phenytoin or sodium valproate, which can cause increased slight elevation of alpha fetoprotein. Then alpha fetoprotein can also increase slightly after initiation of chemotherapy because of tumor lysis. This should not be taken as disease progression or chemo resistance because it is generally transient and becomes normal as we move in the treatment. Now coming to the second tumor marker, which is beta FCG, it's a 45,000 kilodalton glycoprotein, has alpha and beta polypeptide chains secreted by syncytial trophoblast. Normally it is not seen in the serum and half-life is 24 to 36 hours. It's raised in almost all cases of choriocarcinoma, 60% of embryonal carcinoma, 25% of yolk sac tumors. Importantly, 7% of the patient may have raised beta FCG, but here the rise is not more than 100. It is also increased some GI malignancies like pancreas, prostate, and bladder, but as such, we don't see this in pediatric population and is of not much clinical significance to us. And it can be also spuriously elevated with drug abuse, especially marijuana. The third tumor marker is lactate dehydrogenase. Here I would like to point out that there is significant interlab variation in LDH values. So we should not report the absolute LDH value. In fact, we should see how much it is above the normal limit. That is more relevant. Then LDH is not as specific as alpha fetoprotein and beta FCG, and decision about increased tumor markers should not be solely based on just LDH. and it is elevated in 60% cases of non-seminomatous germ cell tumor and 80% cases of seminomatous germ cell tumor. So now let's move to the testicular germ cell tumor. So whenever we have a patient who has a testicular mass and we are suspecting testicular germ cell tumor, the initial staging workup include contrast enhanced CT abdomen and chest. So PET scan is not routinely done in the testicular germ cell tumor. It is of limited value and should be done only in a clinical trial setting or in context of a study, because it does not reliably identify disease in the sub-centimeter lymph node, which is generally seen in the germ cell tumor. And only FDA approved indication for PET scan in germ cell tumor is in patients with the seminoma who have completed their treatment, have more than 3 centimeter residual disease, and we are unsure whether this is having some viable tumor or not, and PET CT can help us in that distinction. Because had it been non-seminoma germ cell tumor, then we could have relied on the tumor marker. But in seminoma, because tumor markers are normal, then in this case, PET scan may be useful. So now we have done the CT chest and CT abdomen. What do we see in the images? The lymphatic drainage of testis is in the retroperitoneal lymph node. Here I would recommend all the fellows to learn about the testicular lymphatic drainage of right side and left side, because it is very important and often asked in the exams. And when do we call this retroperitoneal lymph node to be significant? Generally, most of the investigators take a cutoff of 1 centimeter, and more than 1 centimeter is generally disease related. However, COG group consider 1 to 2 centimeter as suspicious, and if it's a stage 1 tumor, they keep these patients under observation, repeat imaging after 4 to 6 weeks. If the lymph node is still 1 to 2 centimeter, they either biopsy it to prove whether it is diseased or not, or they subject them to chemotherapy. Then generally there is ipsilateral lymph node involvement. If the nodes are involved on the opposite side also, it is generally from the opposite tumor, opposite side, opposite testis, I mean. But if the patient has undergone local surgery, especially retroperitoneal lymph node dissection, it may break the barrier and the contralateral lymph node may also be positive. Testis does not drain in the inguinal lymph node, so generally we don't see inguinal lymphadenopathy. However, if we have inguinal lymphadenopathy, it is either because of the transscrotal violation prior to the surgery, or tumor is big enough and it has involved the scrotal skin. Then in every patient of testicular germ cell tumor, we should look at supraclavicular lymph node also, and because supradiaphragmatic spread can occur via thoracic duct in patients with testicular germ cell tumor. Then after imaging, most of these patients go upfront high inguinal orchidectomy. And what do we have to see in the histopathological report? Basically, we have to see whether we have done R0 resection and there is no microscopic disease left behind after the surgery. So capsule should be intact. There should not be any tumor deposits in the epididymis and tunica albuginea. And cut end of the spermatic cord should be free, and also including proximal 5 centimeter, all margins should be free. Lymphovascular invasion should be noticed. This is not part of staging, but some of the investigators consider this as a poor prognostic factor, and even if it's a stage tumor, stage 1 tumor, they subject them to chemotherapy. However, it is debatable, but this has to be seen in the histopathological report. So after this, we have to stage the patient, and stage 1 is defined when the disease is entirely limited to testis. It is completely resected by high inguinal orchectomy, or if transscrotal orchectomy has been done, it should be without any spill, although this approach is generally not recommended. There should be no clinical, radiological, or histological evidence of disease beyond the testis. Tumor markers should normalize after appropriate half-life, and this is called stage 1. So in stage 1, basically disease is totally limited to testis and there is no microscopic disease left behind. However, if there is microscopic disease left behind, or there is a spill, or there is a retroperitoneal lymph node involvement, which is 1 to 2 centimeters, then we call it stage 2. However, and if the lymph node is more than 2 centimeters, it is stage 3. And if it is like metastatic to the visceral organs, it is stage 4. Now coming to the risk grouping. The watershed moment in the management of germ cell tumor came with the creation of this international germ cell consensus classification in 1997, where 5,000 adult patients of germ cell tumor from North America and Europe were classified as good, intermediate, and poor risk, based on the histology, site of primary disease, location of metastasis, and elevation of tumor marker prior to initiation of chemotherapy. This classification was then applied to the pediatric population. However, there was a low correlation with either stage or risk group. Keeping this observation in mind, it was thought that we should have a pediatric specific germ cell risk certification, and COG group did a collaboration with UPCCLG, and they combined their 25 years of pediatric GCT clinical trial, which were like 7 clinical trials, and they form a consortium, which is like famously called MAGIC. And they did a multivariate analysis retrospectively on the set of more than 1,000 patients which were treated in the 7 clinical trial. And what they found, 3 most important factors which were determinant of inferior event-free survival were extragonadal location, stage 4 tumor, and the age more than 11 years. So how was it different from the adult data? In adult, the histology was of significance, but in the pediatric data analysis, histology was of borderline significant. The preoperative tumor marker were highly significant in the adult data, but they were not found to be prognostic in the pediatric analysis. So based on these 3 findings, then the COG proposed this risk grouping, and this is being followed worldwide in most of the pediatric study. So here all stage 1 tumor are classified as low risk and have event-free survival more than 95%. And the poor risk patients are identified as stage 4 who are more than 15 years of age and IGCC poor risk. And IGCC poor risk, how they define it? The patient should have non-pulmonary visceral mets, which is mostly in the liver, or their AFP is more than 10,000, beta HCG more than 50,000, or LDH more than 10 times upper limit of normal before starting chemotherapy. This poor risk patient constitute around 15% of the whole group, and rest of the patient are classified as standard risk, which have an event-free survival between 80 to 95%. And they are further subdivided into 2 stratum, IR1 and IR2, depending on the age mainly. Less than 10 years are IR1 and IR2 are 11 to 25 years of age. Now, moving on to ovarian tumor. So whenever we have a child with a ovarian mass, we initially do ultrasound abdomen, followed by most of the time contrast enhanced CT abdomen. And what do we see in the images? We see the size of the tumor, whether this is totally resectable or an unresectable mass, whether it is a cystic or solid, then whether unilateral ovarian involvement is there or both the ovaries are involved. We see additional findings of lymphadenopathy, ascites, or mental deposit, or liver involvement. So why do we need to see all this, and what is the importance of this? It is not just important from germ cell tumor point of view. We have to make a distinction whether this is likely to be a benign tumor or a malignant tumor. We have to remember that more than 80% of masses in ovary in children are benign. So if we are suspecting it to be a benign tumor, then we don't have to do the salpingo-oophorectomy, and we should try to preserve the ovary. And how can we make the distinction? So this is a study which was published in the Journal of Pediatric Surgery, and it was quite a large study where they found that ovarian masses that are less than 10 centimeters, primarily cystic and have negative tumor marker, are most likely benign. And in these patients, viable ovarian tissue is frequently present, and significant effort should be made for ovarian preservation. So this distinction based on the radiology is very important. That is why we need to see this radiology very carefully and discuss with our surgical colleagues. Then if we decide that it looks like a malignant tumor and we have to subject them to surgery, feasibility of surgery, we discuss it with our surgical colleague and plan the surgery. So what we should do, we should ask our surgical colleague to do complete surgical resection of the intact tumor, and the capsule should remain intact during the surgery, and salpingo-oophorectomy should be done. The peritoneal washing should be sent for cytology to look for malignant cells. And these are the 3 areas where things were not very clear now, but we have now consensus that contralateral ovarian biopsy, omental biopsy, and lymph node routine sampling is not required, but it must be done if they are abnormal on the imaging or during surgical exploration. So based on this finding, surgical-pathological finding, then the staging is done. The stage 1 tumor is defined as disease when it is totally limited to ovary and is completely excised. It is negative for malignant cell in the peritoneal washing, and there is no clinical, surgical, or histological evidence of disease beyond the ovary, and tumor markers are normal after appropriate half-life. This is almost similar to the stage 1 of testicular disease, where there is R0 resection and there is no microscopic disease left behind. And similarly, in the stage 2, if microscopic disease is left behind, or there is lymph node which are less than 2 centimeter with negative peritoneal washing, and tumor marker here may be positive, it is called stage 2. However, if the macroscopic disease is left behind or only biopsy is done, or there is positive peritoneal washing, it is stage 3, and distance metastasis is stage 4. Just to make it more clear, we can see this. This is like a stage 1 tumor where complete ovary has been removed. We can see the capsule is totally intact, and the adherent fallopian tube can be seen by the side. So it is stage 1. Then if we see here in the intraoperative, there is a capsule breach. So it's a stage 2 tumor. And like here, we can see that the peritoneal deposits are there, and the peritoneal washing was positive for malignant cell. It is stage 3. So I'm not going into detail. This is the FIGO staging, which is generally followed in the adult population, but some of the pediatric centers are still following it. So I'm just briefly telling about the FIGO staging. The stage 1 is when tumor is totally confined to the ovary. Stage 2 is when tumor involves one or both the ovary with pelvic extension. However, if it has crossed the pelvis and has reached the abdomen or retroperitoneal lymph node, it is stage 3, and stage 4 when it is a distant metastasis. So there are basically 2 points that I would like to highlight, which are different in the pediatric staging from the adult staging with FIGO staging. One is like microscopic residual disease, which is considered as stage 2 in the pediatric staging system. It is stage 1 in the adult staging. And the peritoneal cytology, which is positive for malignant cell, is stage 3 in the pediatric staging system, but it is still stage 1 in the adult staging system. These are the 2 main differences in the pediatric and adult FIGO staging. Now coming to the risk grouping, testicular tumor, all stage 1 tumor are classified as low risk and have event-free survival more than 95%. And all stage 4 patients, which are more than 15 years of age, are poor risk. Rest all patients are classified as standard risk. Again, they are classified based on the age. If age is 0 to 10 years, then it is IR1. And if the age is more than 10, then it is IR2. Now coming to extragonadal germ cell tumor. So 3 most common sites of extragonadal germ cell tumor are sacrococcygeal, mediastinum, or retroperitoneum. So generally in the gonadal germ cell tumor, we do upfront surgery to avoid chemotherapy to a subset of patients, especially stage 1 patients. However, in extragonadal germ cell tumor, often tumor is large and they are not completely resectable at diagnosis. So anyways, they receive chemotherapy. But sometimes the surgery may be like indeterminate, whether it is possible or not. If the tumor is very large, the violation of tumor capsule is common. And in that case, anyway, they will receive the chemotherapy, and adding surgical morbidity in this patient would be of no benefit. So it has been seen and it has been proven in many studies that we should not attempt a complete resection unless we are sure that we can remove it totally. Just to avoid chemotherapy, surgical resection should not be done. Here, I would like to mention one more point. In any patient with mediastinal or retroperitoneal germ cell tumor, ultrasound bilateral test, this is very important. Because generally, what we see in the pediatric tumor, the primary site is large and clear-cut than the metastatic site. However, germ cell tumor is an exception where the primary disease may be very small and clinically not visible. And therefore, a patient with a large retroperitoneal mass may be actually testicular germ cell tumor. So ultrasound tests should be done in every patient with extragonadal germ cell tumor involving retroperitoneum and mediastinum. Coming to the staging, the 2 basic investigation that we do for every germ cell tumor is contrast intensity chest and abdomen. So is the case with extragonadal germ cell tumor also. And this is the staging. And in fact, if you see the staging principle are almost the same. Stage 1 is like when you totally remove this and there is no evidence of disease beyond the primary site. In stage 2, the microscopic disease is left behind, lymph nodes are negative, and tumor markers may be positive here. But if the gross disease is left behind, then it is stage 3. And in stage 4, you have distant metastasis, mainly in the liver. So there are a few more important points for extragonadal germ cell tumor. They are almost never low risk by most of the group, especially the COG group. And primary mediastinal risk tumors are considered high risk by many investigators as they are at least stage 3 at the time of diagnosis and not resectable. So this is like COG stratification for extragonadal germ cell tumor. If you see the extragonadal germ cell tumor, which are stage 1 and 2 are classified as intermediate risk. There is no low risk extragonadal germ cell tumor, and stage 3 and 4 are high risk extragonadal germ cell tumor. So UK CCSG group, however, consider the tumor which have undergone complete resection at the time of diagnosis. They take it as low risk, but COG doesn't consider extragonadal as low risk. So coming to the conclusion, as is case with the most of the pediatric solid tumor, multidisciplinary approach should be followed in the germ cell tumor as well. We should discuss every case with the radiologist to see all important findings, then discuss the case with the pediatric surgeon for feasibility of surgery. And appropriate surgery is very important for accurate staging and destratification. All those points that we discussed should be noted in the histopathological report and the radiology report. And this appropriate surgery may help to reduce the burden of treatment, especially in the stage 1 tumor. This is a very important finding that I just got to know while I was reviewing the literature for staging. A 20-year-old treated for testicular cancer has a 47% chance of second malignant neoplasm by age of 70 years. So if somehow we can do appropriate staging and try to avoid chemotherapy for stage 1 tumor, I think this is worthwhile because this chances of second malignant neoplasm is so high. So if we try to keep this patient under observation, we should follow tumor markers very closely after surgery. And basically, we need to have a multidisciplinary approach involving radiologist, then pediatric surgeon and pathologist, and do appropriate treatment for these patients. And I think Raghu will be discussing about various things that we see in the management from treatment point of view. Thank you.
Thank you, Dr. Sandeep, for that wonderful overview on risk stratification. And now there are a couple of questions, but what I think I will do is actually invite Dr. Raghu to please speak first, and then we can open questions out to the entire forum, if that's all right. So welcome, Dr. Raghu, to this forum. He's not new to any of us. He's senior consultant at the Tata Medical Center in Kolkata, and he'll be talking to us more about the management of germ cell tumors. Welcome. You can share your screen, please.
Thank you, Dr. Vandana.
Yeah, we can see.
Okay.
Yeah.
So Dr. Sandeep has described in detail regarding the risk stratification in pediatric germ cell tumors, and in my session I will try to see how we can apply this risk stratification for pediatric germ cell tumors. So before I go to the actual management, what is the rationale behind using this risk stratification, and why do we need a stratified approach to manage pediatric germ cell tumors? So germ cell tumors in children have a bimodal distribution. Germ cell tumors seen in young children up to 4 years or up to adolescents behave differently from the germ cell tumors in adolescent, young adults, and older adults. So this difference in clinical behavior is one of the major reasons why the age cutoff of pre-adolescent and adolescent groups have been incorporated to the risk stratification. So if you look at this table, is a nice table which shows the difference based on the location, the histology, the biology of the tumor across the age groups. So up to the pre-adolescent or the early adolescent age group, it is different, where the location is mostly in the testicular or the sacrococcygeal region. It changes to the testicular, mediastinal, and ovarian tumors in the older adolescents, and in the older adults predominantly the testicular, the testis is most commonly affected. So it is not just the site or the histology that varies. The clinical presentation is also different, with the older adolescents presenting with advanced stage disease more frequently. Up to a third of these patients may have metastatic disease at presentation, compared to only 5% in prepubertal disease patients with germ cell tumors. And outcomes also vary across the age group, the gender, age, and the type of tumors. as we have already discussed, extragonadal germ cell tumors seem to have very poor outcomes compared to the gonadal germ cell tumors. Young females with ovarian germ cell tumors seem to do well with almost 85% to 97% EFS and overall survival. You look at the adolescent males, they don't do so well, with only 60 to 70% having 5-year event-free survival, which is much worse than even older adults, young adults, and the prepubertal children with germ cell tumor. So the underlying biology and as to how to improve outcomes, how to reduce toxicity, these are the goals of current research and the basis of doing a risk-stratified approach. The MAGIC Consortium has been actively pursuing these goals, and today's discussion will also be centered around the MAGIC approach to risk-stratified treatment in germ cell tumors. So Dr. Sandeep again has discussed the initial diagnosis, staging, and risk stratification in detail, including the detailed clinical history and examination, imaging, the importance of tumor markers and histopathology in arriving at a proper diagnosis, staging, and risk stratification. So if you go on to the general approach to the management of germ cell tumors, once a diagnosis is made, if surgery is feasible, then surgery is the first modality of treatment. Following the surgery, you decide whether chemotherapy is required and how much chemotherapy is to be given. In case of an unresectable tumor at diagnosis, neoadjuvant chemotherapy followed by residual tumor excision is the general approach. Now, we may not be pediatric surgeons, but we need to have a basic idea about surgery in germ cell tumors. Again, the previous session, we have discussed why staging is very important in arriving at a proper risk stratification for patients with germ cell tumors. So whenever feasible, upfront surgery with complete excision is the goal in germ cell tumors. And when it is not feasible, neoadjuvant chemotherapy, especially when the tumor is large and infiltrating surrounding critical structures, will help us to do a complete resection at the end of chemotherapy. And going site-wise, in ovarian germ cell tumors, the standard of care now is fertility sparing approach. The opposite ovary needs to be biopsied only if it looks abnormal on examination. And peritoneal washing and examination of the peritoneal cavity should be done in detail. Look for any abnormal looking peritoneal implants, lymph nodes in the abdomen, and biopsy from appropriate sites should be taken during the time of surgery. In case of testicular germ cell tumors, the most important aspect is that a high inguinal orchidectomy should be attempted in all cases. Never uses scrotal incision for resection or biopsy in these cases. And one important question is whether retroperitoneal lymph node dissection is required in all cases. Now, imaging can give us an idea regarding the involvement of the retroperitoneal lymph nodes. And in young children, retroperitoneal lymph node dissection or sampling is not indicated even with suspicious nodes on imaging. Whereas in postpubertal boys, the RPLND might be indicated if they have suspicious enlarged lymph nodes at the end of completion of the chemotherapy. Mediastinal germ cell tumors and retroperitoneal germ cell tumors are often tough. They come as huge masses, often infiltrating the critical structures and may be difficult to resect out upfront. So in most of these cases, we need to do neoadjuvant chemotherapy followed by complete excision if feasible later on. Sacrococcygeal teratomas are another important group of tumors, often very difficult to manage. And the type of surgery depends on the Altman type of classification. The most important point here is that the coccyx should always be dissected with the specimen. Retaining the coccyx has a higher chance of a local recurrence in sacrococcygeal teratomas. So if once the resection is complete, the first question is whether the patient needs chemotherapy at all. So in one word, the answer is no. All patients do not need chemotherapy in pediatric germ cell tumors. So we have a risk-stratified approach, and there is a subset of low-risk patients in this group of patients who do not need any chemotherapy, only active surveillance is required. And even if there is a recurrence, most of these patients can be salvaged, and the overall survival remains unaffected.
So how do we decide who needs chemotherapy and how much chemotherapy do we need to give? So this is based on two aspects. One is the histopathology and the other is the risk stratification that we have already discussed. The most important factors involved in the risk stratification are the site, age, less than 11 years or more than 11 years, the stage of the tumor, and the tumor markers. Histopathology, broadly, we can classify them into benign and malignant, or those with malignant potential. Benign one being mature teratoma, and the others are immature teratoma, yolk sac tumor, and so on, which we have already discussed. So the magic approach for malignant germ cell tumor is based on stratifying tumors into three categories: the low risk group, the standard risk group, and the high risk group. So almost all the stage 1 tumors of all ages and all histology, the current approach is to do surgery alone, and following which the patient has to be on active surveillance. Patients who show evidence of recurrence on biochemical follow-up with serum tumor markers or on imaging will go on to receive more chemotherapy. Whereas the standard risk patients, which include patients who are stage 2 onwards, will require chemotherapy. And this is divided into two subgroups: standard risk group 1 and standard risk group 2. The major factor is the age. So as I said, age is a critical factor in determining the outcomes in pediatric germ cell tumors. So most of the patients above 11 years will undergo chemotherapy. Whereas if you look at the high risk group, the age more than 11 years and stage 4 ovarian tumors and stage 3 for extragonadal tumor fall under this category. So this group of patients are not eligible to be to follow the AGCT 1531 protocol, which is the current protocol that we use for standard risk patient. So if you follow the magic approach, most of the tumors, as I discussed earlier, will require only surgery if the serum tumor markers are normal, and they need active surveillance after the surgical excision. So going on to the management based on the histopathology, the mature teratoma, the standard of care is surgery alone. No further treatment is required. For immature teratoma, surgery is sufficient in most cases. And in pediatric age group, if you look at even advanced stage immature teratoma, chemotherapy has not improved outcomes. So in a select cases of immature teratoma, neoadjuvant chemotherapy might help in improving the resection. Apart from these cases, chemotherapy is not indicated in immature teratomas. Dysgerminomas and seminomas require treatment if the staging is beyond stage 1, and most of them receive platinum-based chemotherapy, and outcomes are excellent. So there's a comparison between the cisplatin and carboplatin-based regimens, and all age groups, including the young age group, the younger age group children, adolescent, young adults, all of them uniformly do well in this subset of germ cell tumors with platinum-based chemotherapy. So coming to non-germinomatous germ cell tumors, what is the optimum chemotherapy? So what are the drugs which are active in this setting, and how much chemotherapy should we give? So cisplatin, as we know, is a very active agent in germ cell tumors, and it has been a part of standard chemotherapy since 70s. So later on, many centers and national cancer programs shifted to carboplatin-based therapy. The disadvantage of cisplatin being significant nephrotoxicity and autotoxicity, which is mitigated by use of carboplatin. The other important model chemotherapeutic agent is bleomycin. Standard of care was giving weekly doses of bleomycin, 3 doses per cycle. This had a higher risk of developing pulmonary toxicity. Other active agents included etoposide, ifosfamide, actinomycin. But the general standard of care for most of these patients include these 3 agents: bleomycin, etoposide, and platinum analogs. So which one is better, carboplatin or cisplatin, and how much bleomycin should we give? 3 doses or a single dose is sufficient? These are the questions that have been of concern and which are being addressed by the various trials. So this is a meta-analysis of germ cell tumors in the pediatric age group. So they found that most of the patients did well on either of these regimens using carboplatin or cisplatin. These two lines at the bottom are the poorest patients. Even here, there is no significant difference between the carboplatin group and the cisplatin group. Though we can see that the poorest group seem to fare much worse than the standard risk or the low risk groups. And the UK CCG has been using the carboplatin-based regimen for quite a long time. Their analysis in 2019 also confirmed the efficacy of carboplatin-based regimens in germ cell tumors. And even with the high-risk group of patients, carboplatin seemed to do a very good job. In the low-risk patient, they used a similar approach as in the current MAGIC approach, where they did active surveillance for patients with low-risk disease. And you can see that though the event-free survival is low, the overall survival is almost 100% for the low-risk patient with this regimen. So they used 4 cycles of JEB for patients with the low-risk and intermediate risk group. And for high-risk patient, they used the same regimen for 6 cycles. But you have to remember that the stratification is slightly different from IGCC and the AGCT classification being here. So we cannot exactly extrapolate this data into practice. So the other question was regarding the dose of bleomycin. How much bleomycin has to be given? So to reduce pulmonary toxicity, bleomycin 30,000 units versus bleomycin 90,000 units was compared in a trial by the Australia New Zealand cancer group, and they found that the higher dose of bleomycin significantly improved the outcomes. As we discussed earlier, the adolescent age group fare worse compared to the remaining the other 2 age groups, as young adults as well as the younger children. So one reason might be using underdosing the patients with a lower dose of bleomycin. So in the current ongoing the AGCT 1531 trial, all the standard risk patients above 11 years will receive weekly bleomycin, so that they are not underdosed. So this two analysis probably give the background and the rationale for using the current chemotherapy regimens in the pediatric germ cell tumors in the AGCT protocol. So patients who are classified under the standard risk 1 group, they will receive 4 cycles of at 21-day interval of JEB or cisplatin based chemotherapy. So generally many centers in India tend to prefer cisplatin based regimens. We have been using carboplatin for the last 10 years. So this small b indicates single dose of bleomycin. So only 1 dose of bleomycin in each cycle. Whether it is cisplatin or carboplatin, we will come to know once the trial is completed. We will get more information regarding this. And if the patient is in the standard risk group 2, then they receive 3 cycles of JEB or PEB. The capital B indicates 3 doses of bleomycin. So again, the choice of using whether it has to be carboplatin or cisplatin is center dependent, but the dose of bleomycin in this age group has to be 3 doses per cycle. For the poor risk group, which includes older adolescent with advanced stage ovarian and extragonadal germ cell tumor, or those who fall under the IGCCC high risk group, the standard of care is cisplatin, bleomycin, and etoposide. Though carboplatin might be effective in this group also, cisplatin is the preferred agent across the world in this poor risk group disease. Cisplatin with 3 weekly doses of bleomycin and etoposide, 4 cycles at 21-day interval is the standard of care. Now the question is whether interval compression can achieve better outcomes. So there is some preliminary data to say that when you are giving 14-day cycles of the same regimen, the outcome seems to improve. So whether this can be seen in a larger population is the subject of the ongoing AGCT 1532 trial. The way it has worked for immune sarcoma, whether it will work also in germ cell tumor. This also is accruing, and possibly by the end of the year, the recruitment will be complete. Another controversy is the use of consolidation therapy, what we call as the consolidation therapy in germ cell tumor. So do we need to give chemotherapy when we see viable tumor in the residual masses that we excised out after the treatment, after the chemotherapy. So earlier it was standard of care to give 2 to 3 cycles additional chemotherapy of the same regimen to cover for this presence of viable tumor in the excised specimen. But in the current HSCT trial, this is not recommended. This is one of the studies, this is an adult study actually, which showed patients who had not received any more chemotherapy did as well as patients who received chemotherapy following excision of tumor and who had viable tumor in the residual specimen. There is data from the pediatric group also, especially from the data from the EGCT 10132 trial, which is the predecessor of the current trial, where patients who were intended to get chemotherapy but were not given chemotherapy after the excision did equally well. So that is why in the current trial also they have not recommended to give consolidation chemotherapy, and giving more of the same might not translate into better outcomes. But again, this is a little bit controversial, so a case-to-case decision may have to be taken in this setting. Two important things that we need to be aware of while we're treating germ cell tumor is that on follow-up of patients who are undergoing treatment, when you see a residual tumor growing back, or what we think is a tumor growing back, can be due to two reasons. One is growing teratoma syndrome. It can happen with any germ cell tumor where the benign component of the tumor starts growing. And especially when you give chemotherapy for immature teratoma also, there's an accelerated growth of the benign component of the tumor. And the only effective management in this case is surgical resection. Actually, the tumor markers will also be negative in this situation. Another important aspect of management of germ cell tumor is the possibility of secondary somatic malignancies within the tumor. Now, this can happen at the beginning of the treatment itself, that the patient might have this component, and or it can also happen at relapse, that this more aggressive somatic element, usually it is a PNET or a sarcoma, it can grow back, and the treatment has to be changed accordingly. So apart from an actual recurrence, these two possibilities also have to be considered while we are following up the patient. Now, after treatment, based on which risk group the patient is in, there is up to 10% to 30% of the patient may have relapse or recurrence. I'm not going to discuss the salvage therapy in detail, but a broad outline is that when there is a recurrence in a chemo-naive patients, that is, say the patient is a stage 1 patient who on follow-up as a recurrence. In those patients, then chemotherapy has to be given as per the upfront therapy, as per the standard upfront therapy. So either with GEB or BEP, treatment has to be offered. Now the problem is with patients who are relapsing after receiving chemotherapy. Here the standard of care is platinum-based therapy, usually carboplatin, and paclitaxel is also a very active agent. The controversy in this setting is whether we need to consolidate such patients with high-dose chemotherapy after giving standard dose chemotherapy. So there have been studies which show that it is beneficial, and there are studies which show that more benefit of adding high-dose chemotherapy in this setting. So the ongoing trial, that is a Tiger trial, URTC 1407, is trying to address this question, where patients are randomized into getting paclitaxel ifosfamide carboplatin alone, or they get carboplatin with ifosfamide with paclitaxel, followed by 3 cycles of high-dose chemotherapy with carboplatin etoposide with autologous rescue. And they are also looking at the validation and the efficacy of this approach using a risk stratification known as the International Prognostic Factor Study Group classification for relapsed germ cell tumors. And this will give us some idea regarding the use of high-dose chemotherapy and which patient might actually benefit from this therapy. A lot of attempts have been made to use various kinds of targeted therapy, but most of these have not worked, including immunotherapy, brentuximab, PKIs. All these things have been tried, but nothing has gone beyond phase 1 and phase 2 in cisplatin refractory patients. Disease monitoring is also an important component of management of germ cell tumors. Traditionally, we monitor the patients with the tumor markers which are elevated at the beginning of the treatment. Monitoring is done during the treatment as well as after the treatment. Imaging is also used to corroborate with the tumor markers. Now, what has changed is the identification of microRNAs, which are universally expressed in all malignant germ cell tumors. This has been validated in, and has been published recently also. So in the upcoming trials, this may be used for risk stratification and taking treatment decision. And this may even do away with the need of imaging surveillance for germ cell tumors as well. But more is yet to come in this regard. And another important aspect that we have to keep in mind, and the whole purpose of doing this risk stratification is to avoid toxicity. So over-treatment of patient unnecessarily will result in unnecessary toxicity. And the major toxicity that are commonly seen in this particular regimen that we used, either be it BEP or GEP, one is nephrotoxicity, which is why we prefer to go more towards the carboplatin than cisplatin-based regimen. Ototoxicity, again, more common in cisplatin, but also seen in carboplatin, and pulmonary toxicity induced by bleomycin. When you are dealing with gonadal germ cell tumors, fertility issues have also to be kept in mind. And patients who face this toxicity during treatment need targeted following during the follow-up of these organs during the treatment. And yeah, this is my last slide, just to highlight the importance of importance of monitoring toxicity, especially ototoxicity in patients receiving platinum agents. This is a normal appearing cochlea of mouse, and this is after giving cisplatin, not weeks or months after giving cisplatin. With just a few hours after giving cisplatin, you can see that the hair cells have underwent apoptosis. So that is how bad platinum-based agents can be with regard to the ototoxicity. So toxicity is also very important when you are managing and just to be kept in perspective by managing, taking treatment decision and following up the patients. So to conclude, germ cell tumors in children have excellent outcomes, and risk stratified treatment will help us to avoid over-treatment and under-treatment of this group of patients. The high risk and the relapsed patients are still challenging. Thank you.
Thank you, Dr. Raghu, for that excellent overview. There are a few questions in the box, and I'll throw it open to both the experts here, Dr. Sandeep and Dr. Raghu. First question is about, is there any evidence if doing FNAC and a cell block, not a true cut biopsy, upstages ovarian tumor to stage 3?
I would say we have to carefully examine our radiology report. We don't need to do FNAC and biopsy in an ovarian mass. If we are suspecting it to be malignant based on the radiology, then upfront surgery should be done. Why do we need to do FNAC or biopsy? And supposedly now patient has come after doing FNAC or biopsy to us, then anyway we have to take it at least stage 2. At least stage 2.
Thank you. The next question here is about role of a PET scan in recurrent germ cell tumors. Is it of any value?
Should I take it?
Yeah, yes, sure, please.
Okay. So routinely, it's not a standard recommendation to do PET scan in staging of germ cell tumor, not in upfront setting also, neither in the recurrent setting also. So generally, how do we decide what kind of staging workup we need to do? We look at the pattern of the disease, where it spreads in the upfront setting and where it spreads in the recurrent setting. So generally it goes to liver or lung, it doesn't go to bone or brain. But if the patient is symptomatic, is having bony pain, and you are suspecting that the disease may be there in the extra these sites, then you may do a PET scan. Otherwise, in an asymptomatic patient, generally it is not recommended.
Thank you. Next question, Dr. Raghu, if I could ask you. In ovarian tumors, if radiology suggestive of an enlarged lymph node more than 2 centimeters or peritoneal deposits, can we forgo upfront surgery and treat it as stage 3, or is surgery mandatory?
So if the patient can undergo complete resection of the tumor, I think you should go for upfront surgery and followed by appropriate staging, and only then proceed with chemotherapy. That would be the best approach.
And I think the next question is in the same line, that in an ovarian mass with normal tumor markers and extensive intra-abdominal dissemination, Should we proceed with upfront surgery? I think you just answered that question. Yes. Or is there a role for neoadjuvant chemotherapy? Is the question here?
No, in this situation also, if we can access of the tumor, then we have, because we do not know what it is, right? The tumor markers are negative. So exactly what are we dealing with? So if possible, get at least a good biopsy, or best approach would be to do a laparotomy and take out the tumor if it is resectable.
Thank you. And it says, is there a role of neoadjuvant chemotherapy? So probably not if the surgery is resectable. Is that right?
Yes.
Okay. So next question's on grade 3 immature teratoma, both intra and extracranial will need chemotherapy. The controversy is around grade 2. I think you clarified that those aspects in a lot of detail. And then the last question about transplant. Would you recommend to transplant or not transplant? And any role of tandem transplant?
So yeah, so that is exactly what I was discussing in that slide on chemotherapy. Yeah, so on high-dose chemotherapy in the setting of refractory disease. So right now we don't have any clear evidence to recommend to do transplant or not to do transplant. This is actually based on the institutional preferences, and most of the institute take a patient-to-patient decision based on the disease status. So I don't think there is right now good evidence to say that all patients have to be consolidated with high-dose chemotherapy. And the current trial is actually tandem transplant. They are giving 3 cycles of carboplatin etoposide back-to-back with autologous rescue. So if that works, then yes.
Okay. And the last question here is on dose reduction or switching to carboplatin for those with audiometric changes while on cisplatin.
So yeah, so I think it is better to follow the protocol defined dose modifications rather than switching the treatment midway. But if there is significant ototoxicity that you cannot give cisplatin at all, then I think you should shift that patient to carboplatin. So otherwise, if you're following up the patient with regular audiometry during the treatment and you find that it is dropping as per the protocol, modification can be done, then stick to the same regimen rather than switching over completely.
And could I request everyone to mute, please, other than the experts? And there's a final question about which patients would you consider JEB, so carboplatin, versus PEB cisplatin? Which patients would we consider?
So actually, I think that is like as I said.
Sorry, just a moment. Can I request everyone to mute, please?
So I think again that is a center preference as of now. We do not have clear data to say that carboplatin is the best agent or cisplatin is better than carboplatin. So many centers have switched over to carboplatin from cisplatin and have good outcomes. So we cannot say by our current stratification that there's a grade regarding actually what to choose, whether it has to be cisplatin or carboplatin. So I would leave it to the central preference.
Thank you. So I think that brings us to the end of the questions in the chat box. Thank you both, and thank you, Dr. Ishita, for presenting this case. Thank you, Dr. Sandeep and Dr. Raghu for coming here this evening and sharing your expertise with us. Wonderful session. I think we hit a century today, so that's fantastic. We had more than 100 participants. So thank you very much. Next session is on January 12th, again, second Thursday of January, and the topic is neonatal thrombocytopenia. We hope to have a slightly different format this time in the form of a panel discussion. So we'll come back then and hope to see all of you trainees and colleagues here. Thank you very much. Have a good evening.
Vandana ma'am, there is a last question with Dr. Venkat. If we can spare just 2 minutes and address that.
Oh, sorry. Which one? Sorry, I didn't see that.
So there's a question.
Sorry. Yes. Oh, sorry. Yes. So would you give? Would Dr. Venkat's asking? Would you give chemo for immature teratoma above 11 years?
So I do not know the exact age cutoff because the COG analysis of immature teratoma extended beyond 11 years, included the adolescents also. they did not find any clear evidence in giving chemotherapy to this crew, even with grade 3 immature teratomas. So I think again that is a subjective issue. Sometimes in grade 3 teratomas which are unresectable, chemotherapy is tried to make it more amenable to surgery.
Thank you. If there's any further questions or oh, there's something else. Sorry. How about VIP protocol in refractory germ cell tumor?
So once it is a refractory tumor, there are no clear protocol guidelines. So the current active agent definitely is that cisplatin. Cisplatin should be included in the regimen, and ifosfamide and blastomicin have also been added to the regimen. So, but general consensus is towards paclitaxel and cisplatin-based regimen. What the third agent should be, again, depends on the central preference. Yes, VIP can list.
Okay, thank you. Any other comments from any senior faculty, or we can bring the session to a close? Okay, looks like everybody is hungry and wants to have dinner, so that's fine. Thank you very much, both of you, for joining us this evening. Thank you, trainees, for joining in, and thank you, ECHO team, for supporting this educational venture. Thank you, everybody. Thank you, Preetham. Thank you, Neeta. Good evening.
Bye.